I want to start by thanking a few people. First of all, I want to thank Ian Powell and the National Executive for inviting me back. And I'd like to thank the management team for all their support. I would say in a long practicing life, I've never been invited back to the same place twice. So thank you for giving me a unique experience, Ian. Today's talk is about physician advocacy, 20th century challenge. This is all about doctors speaking out and speaking up for the public. And there are some common themes, but the literature, I would have to say, is mainly from USA, UK and Commonwealth countries, and so it isn't universally applicable. The lecture today will be about some basic elements of physician advocacy. I'll call that PA if you don't mind, just to abbreviate things. Its origins and its relationship with the recent history of healthcare and the medical profession, particularly 20th and 21st century external threats to healthcare, to medical professionalism itself, and to the status of doctors. All about the current lack of consensus on the appropriate nature of PA, which ravages our profession at the present time. And lastly, a discussion, which I hope will be a frank one, and I hope will be done in a gentlemanly way, and there will be no fruit or anything thrown at me if I say anything you don't like. Now, when it comes to the elements of physician advocacy, they are multiple and they are very complicated, and I've tried endlessly to draw a diagram of them, but I've given it away. It's far too complicated. So I'm going to present it under three headings. First of all is subjects, then methods, and lastly is the issues. Now, under subjects, they're traditionally divided into two groups. There's cases and there's causes. Cases are all about individual doctors advocating for their patients, getting them special treatment and so on. Causes is all about public health doctors talking about issues of clean water, good environment and so on. But I would suggest to you that these are not discrete, they are actually overlapping. Now, when it comes to methods, this, guys, is the whole nub and the gist of this talk. Because in fact, there are three levels of advocacy and we need to discuss them. First, it's policy advice, which is requested by governments or by institutions from medical experts. Second is about closed PA, that's doctors deciding to advocate but behind closed doors. And third is doctors deciding to advocate but doing it publicly through the media and often on social justice issues. Now, I might just act out for a moment the way that our colleges, our establishment would respond to these three levels for you. The first level, policy advice. I smell in the air the whiff of the possibility of a knighthood. Number two, closed advocacy. Well, if we have to do it, but we'll have to be gentlemanly about it, or they'll never invite us back for tea with the minister again. Open advocacy, not on our watch, boy. Okay? Now I want you to think about those because we're going to talk about those in the discussion afterwards. Where do you stand on that? The question is, which of these is legitimate functions of medical professionalism and which is not? Now, when it comes to the issues here, really it's about these things here. It's about the advocators, the givers of advocacy, and there is a spectrum from self-interest all the way through to pure altruism. For the advocatees, the people who are the recipients of advocation, there's a spectrum between them having full autonomy and having no autonomy at all. And lastly, and most importantly from our point of view, is the practical relationship between doctors and the community and patients, which is expressed in this number 3. On the left is paternalism, which is about doctors know best and their collective groups know best. And on the right is all about patients know best. And this is always expressed as a sort of inverse relationship, one against the other. And lastly, it's about individual versus group ethics. This is perhaps the most difficult issue of all, and in fact that relates to distributive justice. Basically, in a word, it's rationing. Advocacy has a very long history. Don't mind if I move around, do you? I can't point with my laser now, so I might as well. Has a long history in Western medicine, was mentioned in the Hippocratic writings, but never actually got into the Ode, actually. It initiated initially in Europe and then moved to North America, and it has changed with prevailing culture and circumstances. During the 19th century, it's interesting that when medical care was ineffective and often, in fact, dangerous, doctors were very keen on advocacy. If you look over here, one of these is labelled snake oil. So what doctors did was they frequently engaged themselves in advocacy in order to build up their authority and their status. 19th century, the embodiment of advocacy was this fellow, Rudolf Virchow. If I ever had a hero, he would sort of be it, really. I'd love to tell you about him. He was the father of modern pathology, or one of them, and he had a very interesting civic-orientated life. He actually manned the barricades in the siege of Berlin, and he fought a duel against an aristocrat who told him to shut up and not interfere in state affairs. I'll tell you how he did that. It's very interesting. This aristocrat actually was a crack shot and an expert swordsman, so he didn't really think there was much to fear from Virchow, because Virchow was a little sort of scrawny fellow. But of course, Virchow, being the guy who was challenged, had the right to choose the weapons. Virchow turned up with 2 culture plates, which he handed over. He said, one of these contains a fatal bacterium, the other one is completely free of anything, and you can choose which one you're going to eat, and I will eat the other one at the same time. Apparently the duel ended at that point. However, he said some very, very good things. He said he seized what I think you can call the zeitgeist, the spirit of the age, when he said that medicine is a social science and politics is nothing but medicine on a grand scale. During the first half of the 20th century, however, things changed dramatically. Medicine became more scientific and safer, and in fact, this chap, Paul de Groif, was perhaps, he was a scientific writer, was perhaps the first to say the phrase, the dawning of the golden age of doctoring. However, the sun began to set on PA at exactly the same time. For doctors, mastering of this expanding knowledge gave them the authority that they needed, and then in true medical style, they felt they had the power they needed, and they had the public trust they needed, and they stopped bothering about advocacy. In fact, at that time, medicine became a dominant profession. these two guys here explain all this terribly well from McGill. It became a state-protected, it had state-protected authority over its area of practice. It had control over associated areas of practice. It had autonomy based upon a strong social contract. So PA became unnecessary. And in fact, success of the biomedical model actually put public health causes into the shade. No one was bothered about them. This was a secure environment, and so doctors, in our true style, saw PA as being undesirable, if not distasteful. So they stopped bothering. However, that secure environment did not last. Along came a series of challenges known to sociologists as countervailing forces. These started about the 1970s. And I've divided them into three groups. There's political, there's technical, and there's some others too, socio-economic. As far as the political forces are concerned, there was a movement at this time to new right ideologies. And with that came the belief that health should be a personal responsibility. In countries with state or corporate dominance of health, in which of course there were many, as this guy pointed out, this is Max Weber, who has a brain the size of a planet, this fellow, or did have. He's in his grave now. But he predicted all of this stuff a long time ago. He said what will happen is there will be a move from substantive rationality to formal rationality. And with that, there is a move from social values to a society ruled by rules and regulations and laws. And that is exactly what has happened. In fact, the corporate and managerialist model led to what has been known in the sociological literature as the proletarialization of doctors. Proletarialization of doctors. That means basically turning doctors into wage earners and making them act as salaried or wage personnel. Thank you. The other force that happened was deprofessionalization. That was well described by this lady. This is Marie Haag from Cleveland. And she described how these technological forces are freeing up information so that it was not previously available to people. Now it's easily available. And she described these socio-economic forces, how a medical marketplace arose where there was increasing consumerism. And interestingly, along with this, pari passu with this, there was increasing awareness of medical self-regulation was failing both society and the patient. So along came a lot of rights organizations debating the role of what doctors should be allowed to do and say. In fact, there were many of them. The combined results of all of these forces was a loss of public trust, failure of the social contract, loss of political support, and a reduced power and autonomy. It's been a sort of roller coaster ride that's happened for medicine. However, as this chap, this is Elliot Friedson, and he is probably one of the most prestigious sociologists to write about the future of medicine and how it's progressed. And what he says is that medicine was surprisingly resilient to all of these changes and regrouped. And it did so by a process called a restratification. And by restratification, it became more hierarchical and more bureaucratic. And what developed, he says, were controlling elites. These are small groups who ruled the rank and file. He's actually talking about the medical colleges. He said there are knowledge elites, these are the universities, they will control the content of knowledge. And then there are the administrative elites. All of these colleges and their associations, and they will ensure that the practice base reflects the interests of the profession. Strong stuff, you know. So, how effective were these CEs, we'll call them, these controlling elites? Well, actually, they did manage to reassure government on self-regulation. They introduced educational programs, they introduced other things like evidence-based medicine and clinical guidelines, and government was to some extent reassured. However, although they did retain some of the professional autonomy, this was done at the cost of clinical autonomy for the rank and file. And they had only limited success in countering the effects of the domination by corporates and others, and the state, on the organisation of medicine. They had very little effect in managing to control our area of work, and they've rarely, if ever, used open advocacy. They were it was a complete anathema to them. And particularly, they avoided social justice issues. So they never strengthened the social contract or increased public trust in the profession. There have been some examples of successful PA in the 20th century, but if you all will remember the anti-smoking campaign, where in fact the colleges came together with a lot of groups from society and did in many countries have what surprised a lot of us in the effectiveness of their campaign against smoking. And bringing the thing a bit more to home, you will recall, some of you at least, how in the 1990s Treasury imposed extremely aggressive plans on Canterbury Health for curtailing its expenditure. So aggressive were they that there were unnecessary deaths and suffering amongst the patients in Canterbury. And the Staff Association, to their credit, produced this document. It's called Patients Are Dying. It says confidential. It mysteriously fell into the hands of 7 irresponsible journalists, and no one can ever remember how it happened. And suddenly the government was very interested, and there was a health and disability inquiry with Robin Stent, resulting in the report on the bottom down there. And that report supported the concerns of the Staff Association and did in fact temper the health reform process, I think. Where are the controlling elites in the 21st century? Well, this guy here, he might not look like it, but he is actually probably the world authority on this subject. Justin Waring, he's called, and he's written a great deal about this. And he says that they're becoming more specialised, stratified and dispersed. He recognises now 6 elites, starting with political and ending with practice elites. And he says that they are professional managerial hybrids, and that they're in power in both the public and the private healthcare system. He further says that they blur the boundaries between professionalism and managerialism, that they have divided loyalties, that they are gagged by employment agreements, commercial sensitivity, and personal fear. So, what is the current status of advocacy? Well, we're all aware that the public-private healthcare system is in a continual state of change, and recent developments like new professionalism and clinical leadership have come along. And we all held out great hopes that they were going to enliven physician advocacy. I have to tell you that the literature has not yet demonstrated any enlivenment of advocacy by either of these new developments. Undoubtedly, there is massive unmet healthcare need, and there is great dysfunctionality throughout the systems, both public and private. And it would seem to me that it's self-evident that doctors are well placed to do the advocation. However, there is, I can tell you, a general lack of consensus about whether we should be advocating, and if so, who should be doing it. A good example of that is the Twin Towers, 9/11. You remember that? Can anyone forget it? At that time, the New England Journal of Medicine implored doctors not to react to terrorism, but to get on with their jobs, is what it said. The Lancet argued that health professionals are concerned with prevention as well as healing, and medicine cannot escape politics, it said. These are diametrically opposed views. So now we are left with two positions which I want us to discuss at the end, please. This is what we'll call the traditional medical ethics position. This, as well as, if you want to read about it, Tom Huddle from Alabama writes about it really well. He says that traditional medical ethics requires that we are competent and that we perform ethically, and that we only provide advice when society acts collectively to improve public health or healthcare access. He says that PA is a political activity. It's neither a professional responsibility, nor is it an element of professionalism. He further says that academic centres should not foster or teach it. This view is supported by a lot of very senior ethicists. This is Edmund Pellegrino, who is, or was, a very famous American, was advisor to George Bush, although I don't think we should hold that against him. He said the assertion of some progressives that activism and public policy can or should displace professional ethics is mistaken. Supporters of this traditional view also say that doctors are too busy to do this. They also say that some are more likely to engage policymakers to advance their salaries and autonomy, and there's tons of information supporting that statement. And indeed, there are studies from both USA and Australia that there is general ambivalence to social justice issues amongst the rank and file in those countries. The opposing view is what's called the open advocacy position. Its chief proponent is this man. This is Russell Gruen, an Australian who has spoken, who is probably, well, he's certainly the Australasian expert in this subject. And he has an international reputation. He says that PA is a professional responsibility and includes political advocacy for not only public health issues, but also social justice issues, including health resourcing and inequalities. He goes on to say that individual action is laudable, but collective action is a hallmark of professionalism. And he says that open PA in the interest of the community will shore up the social contract and regain and retain public trust. There's also quite a lot of support from the academic world for this position. This guy is Mark Everest. He's from the University of Colorado, and he has one of the most currently widely quoted definitions of PA. He says that this is physicians promoting those social, economic, educational, and political changes that ameliorate the sufferings and threat to human health and well-being that doctors identify through their professional work and expertise. And that's pretty clear where he stands. Supporters of this view also say that PA is now successfully included in undergraduate and postgraduate training programs in a number of places in the United States, and that in fact, a subject close to my heart, a lot of university charters actually require academics to be critics and conscience of society. They actually say this is not their right, but this is their responsibility. Events move on in the world, don't they? And the NHS in UK is now massively threatened. It's very interesting how these supposedly very conservative colleges have suddenly got their A into G, actually. This is now a statement that comes out weekly from the Royal College of Surgeons of England, this political update, and it says here the number of times that they've been mentioned in the international media per week and per hour, and that comes out every week. I cannot imagine this having happened even a year ago. It is a massive development. Royal College of Physicians of London, an even more conservative organisation, has realised that contemporary politics is not about leadership, it is about followship. And they have realised that you get to the politicians by swaying public opinion. And they've just released this book, Underfunded, Underdoctored, Overstretched, the NHS in 2016. Again, absolutely inconceivable that they would have done anything like this even a few months ago. So what can we conclude about physician advocacy? Well, I think we can say it's got a long history, and it was very strong when treatments were ineffective and unsafe. It weakened when treatments became effective and medicine became a dominant profession with a strong social contract. Medicine was then threatened by countervailing forces. Politically, perhaps the two biggest ones were the political ideologies which were unaligned with social values, and the loss of public trust were the two big countervailing forces. However, defence of medicine was assumed by these controlling elites. We mean the colleges, we're trying to be polite. But not always effectively. And it is predicted that that will become less and less effective as they become dispersed through the medical workforce. The controlling elites avoided open advocacy, particularly on social justice issues, until these recent threats have appeared, when they have really got themselves going. I wonder whether similar awakenings will occur elsewhere. So I would now be very keen for there to be a debate about where this organisation stands on this subject. And I would say to you there are three critical questions. The first one is OpenPA on social justice issues an obligatory component of medical professionalism, or is it not? And if it is, who should do it? And then, when should we start? Thank you.